Hello, dear friends. I would like to introduce another clinical case that is quite complicated. The fact is that clinical cases allow us to show more clear the theoretical aspects that we analyze at courses, at our educational events and webinars. The fact is that I've understood for a long time ago that dentists are aware of the importance and understand the theory associated with angles, parameter joints, occlusal schemes just when they see how it works in the oral cavity of patients. I will periodically show you the treatment of very complex patients with joint dysfunction, arthrosis, and so on, but I really would hate to have the impression that we are treating joints. In our case, we do not treat joints. I'm a prosthodontist, and we're engaged in prosthetics or orthodontic treatment in our clinic. A whole team of specialists work on this. One way or another during my whole practice, very complex patients came to me which unfortunately were refused by other doctors, and we had to think up something. Therefore, I immersed myself so deeply into the problems of TMD dysfunction to treat patients, do prosthetics for patients with these complications. And after some time, the last 10-12 years, has been formed an additional acceptance for patients who do not require prosthetic treatment. They just refer with dysfunction problems. But once again, all these examples are given so that you could understand that all this theory is related to anatomy, to physiology, the construction of prosthetics. It works even for such patients who have a ton of other problems that needed to be solved. It helps them achieve very serious and long-term results. So in this case, we have a patient with joint complications. It's a total prosthetics, and this is a combined prosthetics. You see that on the upper and lower jaws there are some of all dentures, fractures of the teeth. This is a situation that doesn't allow us to preserve the teeth, and we have to provide an extraction. I separated dental bridges so that the doctor could carefully remove it. And you see, we make such a chart, a diagnostic chart of the patient. That is, where do we start? At first with diagnostics. We assess the state of other systems, the state of specific teeth, whether extraction is needed. Based on these diagnostics, we plan the treatment so that to be ready to move on. The fact is that an assessment of the joint condition is not only one of the aspects of our work, or hypotonicity of the muscles, any problems with joint dysfunction. Evaluation of aesthetic parameters is also very important, so these points are also taken into account. Next, the calculations are carried out to cephalometric analysis, that is, we analyze the skeletal parameters of the patient. The fact is that on what we can focus, the teeth, when we look in the oral cavity, but patients came not only with some old teeth or broken teeth, sometimes they came with no teeth at all. Understanding what kind of skeletal class has patient, what the cranial structure is, the size of the jaws. A comparison of this data allows us to imagine what kind of occlusion, what kind of occlusal scheme should the patient have, what the bite height, the position of the occlusal plane should be. There are so many questions that we can still find out before we directly begin the intervention into the patient's dentition. Well, in this case, you see that we performed the extraction. We had waited for some time, and a temporary denture was made for this patient. And you see that there was acute the alveolar crest atrophy and formed zones of the movable crest. It's not very good, as it will interfere with a removable denture in the future. The fact is that firstly we planned the implantation, but the patient refused it because of circumstances. Of course, for such patients, for patients who have complications from the joint, they need to have fixed prosthodontics, since one of our tasks is to create very good occlusal support in the lateral areas. Well, be that as it may, we always meet the patient halfway, because here again, not everything depends on the indications, on the desire of the doctor or patient's reluctance. There are a lot of factors that form and affect our decision-making about one or another version of total prosthetics. I made a special video about making a decision about total prosthetics, and I think if you look at our channel, you'll find it and then you'll more clearly understand what I'm talking about. So we conduct a classic determination of the height of the bite using template relayouts. The fact is that wax bite allow us to solve a lot of issues related to the fact that we can give to the laboratory technicians the position of the occlusal plane, the height of the bite, and again, static parameters. Further, temporary dentures were made using this wax bite. The height of the bite was adjusted and we took casts. And again, actually at the stage of manufacturing a new denture, we must check a new jaw ratio again. The fact is that temporary prosthetics serves us not only so that the patient can smile while we do permanent prosthetics. Temporary prosthetics is a very important stage which allows us to level down some of patients' problems. Again, after analyzing its skeletal parameters using cephalometric analysis and other techniques, model analysis, we still got a set of data that give us a certain guideline. Our next step, and a very important step, is the evaluation of this data. So, what do we do? Temporary prosthetics increasing the height to that point in accordance with the parameters with that we conceived, and look how the patient responds. And this is not only about the comfort of the patient. The fact is, very often doctors focus on the patient's comfort. It can be created by so many factors, and very often here we can get a mistake. Why? Because the patient says, yes, I like it, everything is super, doctor, but why does he say that? He thinks they will change it to me, it's just a temporary thing, and there will be a new good denture which is much better this one. Therefore, there is a whole set of techniques that allow us to verify this way or another and not just trusting the patient's words but objectively. In addition to the classic ratio of the jaws when I carry out enforced movements of the lower jaw, in this case I use the classic jig. When applying it in such a modification on the lower jaw, using, you see, a small composite register point, I made it using a composite on the central incisor of a removable denture. I made a registration. Front deprogrammers make a number of muscles to relax, which allow us to register a more accurate central ratio. The registration, and then again we double check. Register, set up the teeth, we fix the crowns on the lower front teeth. Having already on the upper jaw a completely precise removable denture that will be permanent for the patient, now we can proceed to prosthetics of the lower incisors, and not just the posterior teeth. We manufacture and install it all in the oral cavity. Next, there is a special protocol for teeth grinding. The fact is that you must understand that we can derive everything using devices. Anyway, we must carry out one or another percentage of grinding in the oral cavity. There is a special protocol for this. There is such a concept as remount of removable dentures. Or we can do a remount of models of your fixed construction and analyze it with devices in the articulator, and this will allow you to carry out a more detailed denture adjustment directly in the oral cavity. And here are the ready dentures that the patient uses for quite a long time. Also, if you look at the slide, you will see that even after prosthetics, we have a very low occlusal index, and we have a good muscle tone, that is, lack of hypertonicity, and the presence of a completely normal reaction to our occlusion. That is what I want to say. The first one, we go step by step from diagnostics to planning, from planning to temporary prosthetics, which is not just a fiction, it's a test element. At each of these stages, with the help of objective methods, we checked whether it has become better for the patient. It must be registered, you must show it to the patient, and only then take the next step. Having worked out the whole scheme, then you can proceed to the permanent non-removable prosthetics so that you will get a good lasting result even in patients with sufficiently expressed dysfunction. They won't have problems, dentures will not break, there will be no complaints on the part of joint because you determined both the jaw ratio and the height of the bite and the position of the occlusal plane. You have defined an occlusal scheme and choose is it a canine guidance or a group function guidance. There are quite clear reasoned indications for it, and you can take the next step. And you see that this works in patients even with such difficult situations in the joint and muscles. Why is it so difficult for us? Because these patients are very labile. For any of our intervention, we can always get a complication, but going step by step, we go around these pitfalls, we see them, and can move sighted, achieving very good results. Therefore, I very convincingly ask you not to rush. Go from diagnostics step by step, sequentially to your successful result. And in turn, I will try to help you with this. Therefore, if you have any questions, you may have any doubts, some comments you can review, come back to see how the teeth was grinded or clarify something. I will always be happy to answer. I'll always be glad to help. And if this question is quite extensive, we'll try to make a video. Thank you for your attention. Let's work on.